City, myself, and I don't systematically do singlet and internal capsules. But in the last 10 or more years, I included the right accoutrements in order to diminish the motivation. The right accoutrements. I saw that, my question is, I saw that the most ventral electrodes, you show that were also functional accoutrements, and I wanted to know if you use them to also affect the accoutrements.
So I will probably repeat it because I'm not sure I understood it completely.
Your most ventral
yes.
electrons in the MRI, I could see they are approaching accoutrements.
Yes, but so the first slide I showed from our study where the tips of the electrodes are. There are some in the vesicles of the stria terminalis, some are in the nucleus accumbens. So it's a cloud of points because in the beginning we did not really know what was the best anterior-posterior position of our electrodes, because when you look in the literature for lesioning, sometimes it's a little bit in front of anterior commissures, sometimes it's 5 millimeters, sometimes it's 10 millimeters, so that was how it was. And we cannot clearly from those data say that the nucleus accumbens is better or not. But are you only talking about stimulation, or are you also talking about lesioning?
I do only lesioning.
Lesioning, eh?
So asking if you use.
Okay, but with lesioning, nucleus accumbens, I think in the past I would have said, yes, Björn Myersson from Sweden, he said you lesion the internal capsule and you also lesion the gray matter down below, which includes the nucleus accumbens. However, then there was the Swedish experience, and so there was a lot of protest because there was an analysis by Brook and the psychologist and others. Myersson was included in that as well, and those patients that were operated really had problems. And so it was a description of all those problems. This is one thing. In China, there's a huge number of surgeries that was performed, lesioning the nucleus accumbens. So it seems that when you lesion the nucleus accumbens, which is the gray matter down below the anterior internal capsule, probably this is something you should not do and stay away from there. And this corresponds also a bit with the findings of the group of Köln. The cold spot seems to be in the nucleus accumbens. So I think be careful with the nucleus accumbens.
So I only do right side.
There are results left and right. We did some study left and right, but there was stimulation. We didn't find it left and right.
Thank you so much. Well, let me ask you something all the time. What do you think about, is the common pathway, or there are differences depends of the target? It's very important, and of course, we can observe difference between the results of Osvaldo Villela in GPIGP in opposition to the intermediate intranucleus in a specific nucleus of the thalamus, no? Do you remember? What do you think about the same pathway for this kind of disorders, or differences between the targets?
I'm sorry, say it again.
Huh?
Let's say it.
Comments? Again? Yes, well.
Summarize.
For all the panels, do you think we are in the same common pathway of the drivers, or are there some difference in different targets about the results? And the second part, you Osvaldo has a very good results in GP, for toilet. Is so different pathway to the thalamus, or is the same pathway? The same is shorter.
I really don't think we are talking about similar, we have similar methods involvement. But there is one study going on from Edward and his fellow, Aizu, has just finished to a collaborative study where he got images from many patients in the world operated on the TPE, TPI, middle thalamus, and so on. And the conclusion, his conclusion by doing that study is that apparently all the responses are repeated by a single common pattern.
Yes.
So you probably don't know Hans Heilen, he's a student of mine, psychiatrist almost, doing PhD, and he's doing similar work like the pathways that I showed, but instead of looking at a smaller window, he now extended the window and actually looking at the sweet spot, there seems to be locus pallidus involved as well. But it's not published yet. So what I think is this is an evolving thing, and at this moment we don't know the perfect answer yet for the different targets and sweet spots.
So we are dealing with complex disorders with multiple symptoms. If you take OCD, for example, patients are very different. Some of them are, counting. Some of them are interested in symmetry. Some of them are hand washing. Others are hoarding, collecting things. These are completely different diseases across different patients, and each patient has different areas of the brain that are involved. So to think that it's one target for everything is not, I think, it's not correct. So I think that in the future, we will decide what circuit is involved in this particular patient. What are the areas of the brain that are malfunctioning in this particular patient? And then choose the most appropriate target for that patient. So to be more personalized rather than one target fits them all. And this is why, all of these targets can have effect. This is why we have 8 or 9 targets for depression and OCD and so on, because all of them have effect. And I think, depression is another good example. We have patients that have sleep disturbance, that have lost libido, that have lost they're suicidal. Other patients that have cognitive executive dysfunction. So we have many different symptoms. These are all in different areas of the brain. And in some patients, one symptom and one circuit malfunction is dominant over the other. So I think that we must go away from this is the target for OCD, this is the target for depression, towards trying to better understand what areas of the brain are involved. And is there a common place that is a hub that we can stimulate and have these very remote activities in different cortical areas. I think we have to move away from one target to choosing the right target for the right patient.
Thank you for your answer.
As usual, Anders, I agree, but now for 90%, Parkinson's disease, rigidity, gait, so many symptoms, and you stimulate in one target, SDN, and it seems to work in patient A and B, and C and D.
No,
There's GPD.
Sorry, not just the SDN. There is RAPO, there is SONICEP.
No, I see.
Yeah. It's so different.
Yeah.
Well,
And that's for the motor disorder, but
Yeah.
OCD is
thank you. Fabián, ¿you want? ¿No? Déjenme decir algo en español, una reflexión. Dijo el doctor Lozano, no hay neuronas que no puedan ser abordadas. Y ahora digo otra cosa que nos dijo nuestro amigo Clemente Lamani. A los neurocirujanos funcionales es a quien más nos gusta el cerebro. Más que a otros neurocirujanos, porque tratamos de tener la anatomía y la función, perdón, es una observación. ¿Quién por acá? Adelante.
Yes, I have comments for that. Thank you very much for your remarkable presentation. If you accept, I would like to be the David advocate. You presented the study from Rick Group comparing the results of capsulotomy versus DBS. You were avoiding to quote the paper from Mao analysis with on the same study comparing the results of capsulotomy versus DBS. And what is showing the paper from Mao analysis is that if the rate of responder is similar, the percentage of patients with a profound improvement with Y-box and the 16 and the 8 is much larger. And in my practice, I'm doing both, and I have exactly the same experience as the conclusion of Mao. And so those who are treated with capsulotomy, we have a lot of these patients who are having a very important decrease in the Y-box. And if I was looking at your very nice slides, and you were presenting all these graphs of Y-box decrease. And interestingly, when you look at it, you see that a lot of patients, you were saying, oh, these patients are improved. You are using this curve, they are better. But when you look at the Y-box, there is a lot of lines which are not reaching 20. So they are better, but they are not that better. And I think in this group of patients, that may be important not only to have responders, but to have the best responders possible. And I think that's, in psychiatry, in my experience, that's the only indication where lesions look like to be better. And I think that's not something we have to put under the carpet.
First of all, I didn't see the carpet. Secondly, I have no advantage in DBS or lesioning. I do 50% lesioning, 50% DBS, so I'm not in favor of one or the other. I fully agree with what you say on the bit better effect with Mara Harris. Actually, we also published a paper that was on scanning, but we also looked at the Y-boxes on DBS versus lesioning. It was a non-randomized control design because I say we do about 50% lesioning and about 50% DBS. And indeed, the Y-box was a little lower, not significantly lower, which means better in the lesioning group as compared to the DBS group. However, the target was not completely the same, and what you're talking about is the target of lesioning is the lesion you see on the MRI versus the volume of tissue activated, VDA. And if that is not perfectly the same, or comparing two different things, so you should, to really control that, you need a control design, and that has not been done yet, as far as I know. But, and so this is about advantages, the Y-box improvement in lesioning versus DBS. But then you also have to talk about the possible risks. And when you have apathy and disinterest, and this is seen in lesioning procedures, much less in DBS, then you have to weigh advantages versus disadvantages.
Thank you.
Other question?
Yeah. Yes.
Congratulations for all the talks, excellent. Just to bring back a little bit of the discussion that Andreas was saying before, being very specific towards targets according to symptomatology. I think this is very elegant. I was always involved with this concept. But if you look, how to explain this? If you look at the depression literature in general, the psychiatrists, they have looked and investigated all subtypes of depression, and they couldn't find any kind of biomarkers, demographics, clinical presentation, subtypes. And also when we talk with our psychiatrists on the OCD arena, they don't like very much to standardize, which, it makes total sense, right? If you have more a thinking, mathematical obsession, like I had a patient who had a problem with 33. It's way more parallel than the one who washes the hands. But this is a very anatomical perspective. and they don't believe on that. So I think this is a big mismatch in our areas on symptoms, presentation, and this. And the second spice for you, but when Jean said about this the lesion, I don't think the size of the lesion that you stimulate can fully represent the effect of the lesion. At least for the manipulated surgery, there is plenty of evidence that the size of the disconnection, the effect is beyond that, maybe from the telemodel. So, and in our experience using one single column here, we had very, very small lesions. And as you know, we failed. And then we came later on, we added the second target. And even doing this, in a later time, 2 years later, we didn't achieve the same results of placing the lesion at the same time. So there is more going on there than simply the size of the lesion.
Husband and wife team.
Yeah, we're bunching against Mark now. Because and why is that? One thing that it's important to put on the table as well is the fact that the PDS, it's great. We all love it, and we learn every time we do one. But at the long time, these patients have other complications, right? Such as decrease of the function of the stimulation, but also all the hardware problems that we have in PDS that are almost 15% that we see in the literature when we do Parkinson. In these patients, you have a lot of experience. How much you see of hardware problems with these patients?
So maybe I'll start the discussion. So first of all, the surgery for psychiatric disorders is evolving, and surgery in general, functional is evolving from surgery of neurons, of nuclei, to surgery of white matter tracts. So more and more, we are not operating on nuclei anymore. We are operating on axons. And the stimulation and lesioning of axons have very different effects. They are not equivalent. If you stimulate the optic tract, you see light. If you burn the optic tract, you become blind. If you stimulate the cortical spinal tract, you get a contraction. If you coagulate the cortical spinal tract, you become paralyzed. So stimulation does not equal lesioning. So I think that's very important. They are very different. In some cases, when we lesion the nucleus, we get the same effect as stimulation. But for white matter, it is completely different. You get the opposite effects. And sometimes it just so happens that if you move the window from above or below the current state, that is giving you a therapeutic effect. You can either increase it or decrease it. It's like if your sodium is, 140. If you go above, if you go to 180, you get sick, and if you go to 100, you also get sick, right? So it's a question of where the window is, and sometimes by inhibiting a structure or stimulating a structure, you get a therapeutic effect. So that is one point. Just the point that stimulation does not equal lesioning. I think that's Second point is that these disorders, all of them, are very complicated. Even in Parkinson's disease, we treat tremor, rigidity. We do not treat the psychiatric problems. We do not treat the balance. We do not treat cognition. So, we are taking individual symptoms of illnesses and choosing a structure in the brain that we think has an influence on that. And, in the future, I think for a sort of like Parkinson's disease, where you have cognitive aspects, depression, motor aspects, we may have to choose multiple targets, not just one target, but multiple targets to address the individual symptoms. So with that, I'll pass it to Mark.
Multiple parameters. Please, Mark.
So, I appreciate your comments very well. Probably the ideal lesion is the best treatment. The question is, what is the ideal lesion? You're talking about a small lesion. If we all know how a small lesion should look like, later on compare with VIM. In the beginning it was VIM lesioning for tremor, then it came the Minabit-Pollack treatment, the stimulation, and now there is the HIFU and so forth. So that's history. Who knows what will happen tomorrow? Yeah, and there's a very nice meta-analysis on the question on complication rate. I actually had a slide behind my talk, but I can show it to you.
Yes, another question? Déjenme preguntarle algo al público, por favor, disculpen, levanten la mano quienes sean neurocirujanos. No, que sean neurocirujanos. Y de ellos, ¿quiénes harían enhancement para funciones cerebrales? ¿Por qué no? ¿Por qué sí o por qué no? Ah. How many of neurosurgeons in the room would you like to do enhancement for cognitive or multiple functions? A little bit.
For normal person,
Normal person. Not patient.
So your question is,
Yeah.
how many journalists would do this kind for normal persons?
Normal person.
You mean change behavior by operation?
Yeah.
Okay, so. Okay, so you want discussion?
Yeah, well, it's a question, huh? You know.
So, you know, he's already high in society. Yes? I mean, take my wife. My wife wants an electrode because her memory is normal, but she really wants a very big memory. So, okay, we can implant her. So she will have a better memory, let's imagine. But her tennis friends see that. And they also want this kind of treatment. But this treatment has certain complications. So you are actually morally forcing her tennis friends to have this kind of operation, because when you have a good memory, you just turn the pages and, well, you know this book and the next book and so forth. So you get higher in society. So everybody wants to win the race. You know, in Belgium, cycling is a real sport. If you take doping, then it's very likely that you will win the race. However, doping has side effects. So you're forcing every racer to take doping. And that's why society interacts and says, no, you cannot take doping. So this is one part of the story. The second part of the story is, I must honestly confess that I am stronger than my neighbor because I enhanced myself by having a vaccination against COVID, a vaccination against influenza. But that's okay, because a vaccination, you have to treat millions of people, normal people. These are not patients. And they are stronger than the one who doesn't take the vaccination. But this is accepted. It's even in many countries reimbursed, this vaccination, because the possible benefits versus the negative sides. It's really a balance to the benefits. Now I take the same operation, so the third part of my talk. The same operation, looking at my left neighbor, Andres Lozano. He does this kind of memory improvement in Alzheimer's. I don't see any problem with that. I mean, these are patients that are suffering, and that's what we all do. So, who will do stimulation for memory improvement if they can in normal people now?
So,
Does it remain, so everybody, I guess?
so do we need a regulation or limits, ethical limits
Yes.
or regulation?
So, every year in the United States, there are 400,000 women that get a breast implant. So, the first breast, plastic surgery was done about 80 years ago for cancer. But now it has become a very popular procedure. And there's a history of this, blepharospasm, the nose, plastic surgery. So these procedures were initially done a long time ago for people with cancer and so on. But over time, they became normalized and were used in people that did not have cancer, that were not going to die, but who wanted to be enhanced. The same thing will happen in our surgery. Right now, we do not do these procedures in people that are normal. We do these procedures in people that are functioning below normal to try to bring them up to normal. But I think it's inevitable that in the future, these procedures will be done in so-called normal who want to upgrade, who want to be better than the others. So I think this is the history. If you look at the latency of time, for example, wide lumen stenosis for cancer was done 100 years ago, but then it took 70 years to do gastric bypass for obesity. Breast implants, it's 70 years. So it's about 70 years between the time of the first operation is done for a very solid complication and the time it's done for an enhancement or a lifestyle purpose. And so based on that, the first operations for memory enhancement were done over 20 years ago. So if you follow the same role in 50 years, you will be doing these operations on normal individuals. That would be my prediction if you extrapolate of other operations. And as you know, people like Elon Musk are very interested in this. They want people to have brain chips for enhancement. So this is going to happen. And it's us to lead the field and to propose what are the guidelines, what are the justifications, etc., what are the ethics of this, because this is coming whether we like it or not.
Thank you so much. Something else? Yes.
Andres has said everything that I wanted to say as well. I think society needs to discuss this. Society will find out that we are a subset of society, and I think the plastic surgery or corrective surgery that also do a lot of surgery for the burns basically is a good example of that. It's pushing the limits. Something that might not have been accepted yesterday will be acceptable tomorrow. And Elon Musk is making exactly that point. He's not interested in curing diseases. That's how he sells things. But his idea about the Neuralink effort and his idea about his brain chip his effort is about he wants to have direct contact to a computer, and that's sure enhancement. Right? This is what this is about. And they are slowly massaging that into us. So we need to have an opinion. I think it's very, very important for us to have an opinion.
Thank you. Mark, please.
So I don't know in the rest of the world, but in Belgium, for instance, these enhancement procedures, when there's no pathology, for instance, I find my nose a bit too long and I make it shorter, this is not reimbursed. So society accepts it, but doesn't reimburse it. You have to find out yourself. So
Even more disparity between those that have resources.
Mike.
It even reinforces the concept of disparities between the haves and have-nots. And rich people will have preferential access to these technologies, preferential access to enhancement, and it will create an even wider separation in society.
Yeah. Please.
Thank you, yeah, for the comment. I think that the key point of my talk was this, the call to action. The call to action because we are more than 100 neurosurgeons and just 3 or 4 raise their hand for according to the neuroenhancement surgery. That was the key point of my talk. are raising their voices. And I think that
Yeah,
that's
that's
dangerous.
that's it.
And I think that we must raise our voices. That's why I said that maybe with the INS and the USSFM, we should say something. Because in, I think less than 50 years, some people with money will buy the surgery for the memory, the surgery for the supper